Hi, everyone, and welcome back for another episode of Circling the Rabbit Hole podcast with me, Dr. Claire Kinuthia. As always, I'm grateful for all the feedback we've been receiving, all the episode suggestions, and I promise we'll get to all of them in good time. For today's episode, I have a guest who I'm really happy to have on set. She's a colleague, a junior colleague of mine. And I feel like sort of like a proud parent in this moment when your eggs hatch and you're like, yay! So I'm excited to have Dr. Jemimah with me on set. Thank you so much for honoring our invitation. Today we talk about maternal health, something that we really haven't. We've tended to lean more towards sexual health and reproductive health in general, but we haven't really focused on mums. And I think it's important that we do. So thank you so much for joining me on set today. As is the tradition with the podcast, I'll start by asking you to introduce yourself. So tell us a little bit about yourself and whether we can find you on social media or not. If we can, what are your handles?
Hi. Hi.
Hi.
Yeah, so my name is Dr. Jemimah Kariuki, Gishuhi. Happily married. Did not think I would start with that. But anyway, yes, I'm a gyna junior, as you said. I graduated last year.
Congratulations.
Thank you.
That's a huge deal.
Thank you. I actually usually say I finished my MEd with an MEd, an organization, a husband, and 2 children. I don't know how I did it.
There we go. Already a superhero. Already.
That's good. Yeah, but yes, I'm on social handles. On Instagram mainly at Dr. Jemimah Kariuki Kishuhi. On YouTube at Wills for Life _
Fantastic. Okay.
We'll also find the same Instagram at willsforlife.life. At willsfor.life, I could not find the underscore.
Oh, right.
So it's
Okay.
fine.
Okay.
Yeah. So that is me. I've been a gyna for 1 year now, give or take. But I've been passionate about maternal health for so long. I think for like now 8 or 10 years.
Okay.
One, because of personal experience. 2, because it seems like that's where I was pushed by God, by life and all that.
Right.
When I was younger, at I think 13 years of age, when menses hit and everyone is excited, I got a discharge. And I didn't understand it. And then I told my mom, and she took me to a gyna who looked at a scan and went like, "Are you pregnant?" And I'm like,
at 13. Okay.
And you should have seen the shock on my mom. So she was like, "Please talk to us. Tell us. We'll help you.
Tell us what you've been up to." Because that's more of an accusation than anything else.
And he sat me down, and for like 5 minutes, that's all he was talking about. And I'm like, I'm a virgin, you guys. I'm a virgin. And then had to go through a HVS at that age. So it was a bit scary. But now that made me think, this is not what patients should experience, surely. It was hyperplasia, but at that age, it's fine. Anyway, so I think the next visit he told me I had PCOS. I think he just I was branded.
Diagnoses were thrown at you.
Thrown at me. Yeah. And then now going forth, I think I did a lot of maternity during my internship because of the doctor's strike. So everything was collapsed to mat or surge. And then everyone was coming from Mombasa. Imagine from Mombasa to deliver a baby. I was like,
where were you?
Surely Moranga.
Oh wow! From
such
Mombasa.
A distance, yeah.
Because again, the system had completely collapsed at that
really
time.
Collapsed. Every time there's a strike, I actually panic because I know it's just going to be mayhem. And then now, during my MEd, now we had the COVID pandemic, and then the pandemic led to Wills for Life, which we'll speak about at some point. Yeah, but I think I've just always been pushed towards mothers and what mothers are feeling, especially during COVID. I was pregnant.
So I was literally going to ask, you're a mom yourself.
Yes.
So how does motherhood or the journey so far influence your work as an obstetrician? Because there must be. So based off of experiences, whatever you're comfortable sharing, of course, experiences you've had along the motherhood journey that have sort of had a bit of a rubbing off effect on how you practice.
Motherhood has a lot of bias, by the way,
Mhm.
on obstetrics. So it has a lot of bias
Mhm.
because one, I tend to feel more when I see a miscarriage
Mhm.
because that's a one, there was a decision I made and then there was a follow-up that was not my decision.
Mhm.
So when I see the pain of miscarriage, I feel it
Mhm.
more and I tend to sort of over-relate
Mhm.
with the
Right.
patient
Yeah.
and sometimes to give hope, sometimes to allow them to cry.
Mhm.
So there's that. Then the pregnancy itself and COVID made me realize just how, I don't know, disengaged
Mhm.
we were
Mhm.
towards pregnant moms.
Mhm.
So you understand that when you're going for a clinic, you'd like to have your partner with you, you'd like to experience to this phase together. But there
Yeah.
was that notion that one, I don't know how to say it. I'm a doctor, so
Yeah.
I know things.
Yeah.
And then I realize I don't.
Yeah. Yeah.
I really
We make
don't.
the worst patients.
I
We
was a
truly do.
terrible. Oh my God. Sorry, Dr. Emma. As a
Yeah.
terrible patient. But then towards the end, I think I got pre-prom.
Mm-hmm. What is pre-prom? We must
Okay, I
speak
need to
English.
speak to patients. I had what looked like liquor or the fluid, the amniotic fluid had come out.
Mm. This is before time
Before
of delivery.
time, I
Yeah.
think around 36 weeks, so I was put on bed rest.
Okay.
And one thing that happened was I was working too much. It
Mm.
was COVID, everyone,
Mm.
doctors, you need to show
Yeah.
up and stuff like that. But I was working more because I was running the organization, but beyond that, I needed money
Mm-hmm.
because I needed to stay outside of work
Mhm.
for like 6 or 9 months
After baby
after
comes.
delivery
Yeah.
because I really wanted to give that whole time for baby at home, 6 months home, which was a big thing for me.
Mm.
But with the
Mhm.
finances behind that, so I think I hadn't factored how much I would require.
Mm.
And so Happy and I really worked in that season,
Right.
but I over pushed.
Right. Yeah.
And then it made me realize quickly that there's a gap in terms of planning financially for pregnancy.
Mhm.
But leave pregnancy alone. There's planning financially for the aftermath, the
Mhm.
baby.
Mhm.
So that really showed me the gap. And then I would get very many calls from moms asking me, where am I going to deliver? And I'm like, you're 9 months. What do you mean, where are you going to deliver? Kwani,
How
what
do you
were
not
you
know already?
doing?
Yeah. Yeah.
And I realized there's just a lot of questions of, is NHIF covering? Is it not covering? The public hospital, is it not? Private hospital, which one? There's a lot of questions that go towards that delivery period that we tend not to think about as doctors.
Yeah.
And I really hadn't thought about it until I sat down as a patient and I was like, there's a big gap in information. Then my second baby came with gestational diabetes, which is increase of the level of sugar because of the hormones of pregnancy.
Yeah. Okay.
Let me tell you,
Okay.
those finger pricks that we
Yeah.
tell patients, why didn't you
Yeah.
measure?
Yeah. It's not easy. It's not easy.
I
It's
hated
only
it.
when you experience some of these things you start to be able to empathize.
Yeah. So I think it's been a journey to understand the patient as a doctor and as a patient myself. And that's the kind of thing that has made me want to teach patients and go beyond the desk and just
Right.
be there and be that gap.
Okay. So then that brings us to Wheels for Life. I'm actually really curious to learn about what Wheels for Life is and how it came into being.
Okay. So Wheels for Life is actually it's a response to a call because again during COVID I was seated at home for the earlier bit, March 14th, around there. Everyone was praising doctors with the flowers and the claps, and I was just at home because I was in a chilled rotation, thank God.
Right.
So I was put on maternal mortality for the month in Kenyatta, where we just check what happened. Is there a thing we could have solved? And then we had a rise in mortalities that month. But what really struck me was the babies. We were getting very bad babies, but bad babies, I mean, the outcome immediately post delivery was not like what we are used to.
Yeah.
So I wanted to find out what's going on. And then I remember one nurse was complaining, that patient has delivered here, because I was working in one of the biggest referral hospitals.
Yeah.
And we get a lot of bad referrals, or we
Mm.
would get a lot of bad referrals. But this one had come in, but they've come in like 15 minutes to delivery. And they had very bad meconium that I'm trying to explain in my head.
The baby had pooped in mommy's uterus.
Yes.
And the big issue with it is they inhale it.
Yes,
So they have
yes,
issues
yes.
with the respiratory system.
Exactly.
Yeah.
So, and I checked and I went back asking the moms, and the issue was transport. So in my head, I was like, curfew is the problem. So I figured if we start telling women to go to hospital earlier, then they would not be caught by the curfew. And that's actually what led me to sharing and telling people, call me so that I can guide on what happens. And I thought that all I do is patient education. Shock.
So when you start something, you realize how much of a gap there is. Yeah.
Then I'd get calls that I've been sent home because I'm not dilated enough, but I'm a previous car. I don't want to go home and all these things. So that's what led to getting very many organizations to round up and give us transport. So we would have patient education and transport. But during COVID, the emphasis was actually the transport. So
this is to get pregnant
women
for
from
delivery.
home to hospitals.
Right.
So we ended up actually doing facility to facility transfer that I'm happy to say at least is ongoing, we thank God. And then we had home to facility transfer, which is from home to the hospital. And then COVID ended, the funding for COVID ended, and I figured the problem was the curfew. The curfew is gone. I'm done.
Yeah.
That was the time I was doing my wedding. I was happy.
Yeah.
But we still kept getting calls from the helpline. We still have the helpline 1196, plugging the helpline 1196. And women would still call asking for, what do I do? My pressure, my headache, and this and that. And I realized the biggest gap was actually in information. And we kept saying the same thing and same thing and same thing all the time, as we were discussing earlier.
Yeah.
So we pivoted greatly now to giving patient education.
Okay.
So that led to us having, I think now we're on the 7th WhatsApp group.
Oh, right. Okay.
Yeah.
Okay.
So we moved from Kenya to Rwanda to Uganda.
Nice.
Just disseminating a lot of information. And I'm really grateful because I have doctor colleagues who show up, not for any pay, not for nothing. They just want to also disseminate information. And then which led to a facility for quality healthcare, which we saw the closure of that facility.
All right. Okay.
And then now another one. Anyway, God has really been guiding us step by step. But the main emphasis that we have is patient education, so that they can have a proper plan for the pregnancy, for the birth, and the child afterwards. Focusing on child immunization, family planning post the delivery, and just ensuring that the women are whole.
Yeah.
I think there's an emphasis on mom, there's an emphasis on baby, but there's no emphasis on the woman themselves,
Yeah.
So the woman goes through a lot of changes before pregnancy, during pregnancy, during delivery, post delivery, and people think it's for 6 weeks. That's a
It's
lie.
not. Yeah. It's not.
Yeah,
It's a life-changing point in time. Yeah.
Exactly.
Yeah.
So you, like, now my baby is 9 months, for example. And I'm still in the aftermath of that pregnancy,
Right.
Yeah. So
While raising two now.
too. Yeah. So one thing that that has shown me is to support the lady, because if you support the woman, then you're able to support the baby, the father, and the mom. The mom in the woman.
Yeah.
So we're doing a lot of community engagement. We're doing a lot of peer-to-peer support. We have super moms now who are doing an amazing job.
Yeah.
really it's evolving every day. I'm
Mhm.
like, okay, this is new, okay, this is
Yeah,
new, and
yeah.
it evolves by itself, and I'm really grateful. And we have an app. Who knows? We have an app.
Oh, nice.
We
Oh,
have an app.
fantastic.
So
Okay.
find us on Google
Okay.
Play Store.
Google Play Store.
Yes.
Okay.
Yes.
We'll put all the details in the description so that whoever needs support or would like to support can reach out to you guys
That would be
directly.
good. Thank you.
So you mentioned having sat going through morbidity and mortality reports in Kenyatta, and because we keep referring back to COVID time. The statistic I have currently is from 2020,
Mhm.
where we had a maternal mortality ratio, which
Mhm.
is how we measure maternal,
Mhm.
either really bad outcomes or
Mhm.
deaths with
Mhm.
mothers.
Mhm.
And in Kenya, I think we were at 500, I'll
And
just refer,
30.
530
Yeah.
deaths per 100,000 live births, which is the scale of measuring. And yet the global average is 223. So meaning we're more than double. That's what that means. And that was
Yes.
as of 2020. Do you think, because again, we've been working towards reducing maternal mortality ever since.
Mhm.
Ever since. We can go back into medieval times when we first discovered how to do a C-section, and it was a guaranteed death for the mother at
Yeah.
that time. And yet, our numbers still stay pretty high, especially here in Kenya. Is the situation any better now? Given, because we've seen everything that's going on with the healthcare system,
Mhm.
we've seen the defunding, we've seen the confusion that came with devolving healthcare. Is the situation any better, or has it gotten worse?
Um, this is a personal opinion because we don't have so much statistics
Statistics, yeah,
currently.
yeah.
But I think devolution initially had good impact
Mhm.
because women would be able to go to the county hospital and it was upgraded to be able to do
Some.
ICU care,
Yeah.
and HDU. But majorly just the upgrading of theater because now more patients would be able to have cesarean section if need be
Yeah, on time.
on
Yeah.
and on time.
Yeah.
And then I think the other thing with devolution is that there was that county to county competition. We are doing better than you, we're doing better than you. And then I think also the health care centers, the health centers level 3 got a bit more support in terms of community health workers and the midwives who are there. But I think also with the devolution came a couple of problems. One, we devolved the human resource, and then we allowed the county to hire doctors, hire medical officers, what are they called? As consultants and clinical officers.
Yeah.
So the preference is to employ clinical officers vis-a-vis medical officers because they're seen to be able to serve more. And up to level 3, I think they can and they do a good job. But over and above that, it would be criminal to ask them to do cesarean section, which, as you've rightly said, would kill people before, and it still does, And even that sensitivity to know, is this time to go to theater and is this time not to go to theater? Because I think for an obstetrician is to know, will this one deliver or not?
Exactly.
I think that's just
obstetrics training as an obstetrician is to be able to manage high risk pregnancies.
exactly
You're supposed to be able to identify this situation requires a bit more.
more care.
Because if it's a standard pregnancy, expected kind of birth scenario, a midwife can handle
Exactly.
it, a
And they do a
clinical
good
officer, and they're
job.
fantastic. In fact, they take the load off so that the obstetrician can focus on the
high
tougher
risk
cases.
pregnancies.
Yeah.
So I think to not have level 4, 5 hospitals with obstetricians is criminal. So the ones that are supported by universities, the Eldoret, Nakuru, Kenyatta, they have a bit more, I don't know, a better outcomes. But for the rest,
Yeah,
it's a scam. It's a scam,
truly is. Yeah.
And the other thing is, we finished, for example, I finished as an MO in 2016. I've never been employed by the county. Not
In
once.
2016.
Yeah. And
Right.
not for not trying to apply
True.
for work.
Yeah.
They just don't apply.
Yeah.
So to have consultants, medical officers hanging doing locums
At home. because there's no,
because
you're not being employed. And
it's
it's not for lack of need. Again, we all
Yeah.
understand the system and how it can be taken advantage of. And we now have such a corrupt system in place. I like to call things what
as
they
they
are.
are. Yes.
We don't
They are.
sugarcoat things on this
Yes.
podcast. And the fact that you sort of now have reached a point where in some counties you have to bribe to get a
To
job,
get a job.
but you are unemployed and have never made any money. So how are you bribing? So then we have lots of, and that's why we've had lots of strikes and a lot of pushback by younger doctors. It's not that it started with the interns, but it got the worst with the interns, because previously with national system, you all got posted, because then the overseeing body, the Ministry of Health, was able to say we have
There's a
greater need
here,
here, we
there's
have greater
need
need here,
yes.
so post more people here, post fewer people here. Now that it's devolved, the counties are supposed to make the decisions themselves, but if you lead with corruption, then you end up with unemployed doctors, but also unmet need in the facilities.
In the same facility. So I think because of that, we're seeing our numbers go higher. In the counties where health is a priority, you can see the impact immediately. Like the numbers are lower. But in the counties where health is really not a priority, you get maternal mortality rates of 1,008.
Which is so
it's
crazy.
So high.
Because we've gone backwards. We had made very good strides, I think, previously. The training is amazing now. The healthcare providers are actually very, very well trained, identifying high-risk mothers and being able to call for help on time.
Yes.
We have a lot of good work by community health workers, identifying at-risk mothers and sending them to hospitals, not trying to deliver at home. We've had so many great strides over the years, and then we start to fall.
And then at the point of the hospital, which is just...
Exactly. Yeah. It's unfortunate to see, but I'm hopeful. I'm hopeful.
We have to be.
Given that sometimes you kind of, instead of sitting and wallowing, you start projects like Wheels for Life, where you're like, you know what, let's figure out, let's not wait. Let's figure out and do something in the meantime and help as many mothers as we can. So now, given your experience as well, again, I like that I can talk to you sitting both as a mom and as an obstetrician with prenatal or antenatal care. What do you think the access is right now? Do you feel that we are any better than we used to be in terms of moms being able to get to hospital or to go in for their clinics on time? Is there an understanding why antenatal clinics are important? Why should you attend them? Or is it just daktari aliniambia nikuje?
I think we are getting there, because you find mothers who want to go to clinics, but I think they go to clinic a bit late. So they know that they need to have gone for a clinic or two before delivery. So they wait until they see the belly, then they go. So especially for women who have lost their pregnancies, I usually feel so sad when you come at 20 weeks with a stillbirth, or just I just feel so sad. So I think the emphasis now is, can we do either the forecast ANC, where they're the 4 visits, first trimester, second, third, and before delivery, or can we do the WHO 8 visits to the antenatal clinic? And I think more women are starting to do so. I think the only challenge or the gap that I'm seeing is the handover from the clinic to the delivery. That's just transitional handover for you, because you find if it's a high risk mom, they're identified, they're transferred to the gynae, but they're told go at 34 weeks. So at 34 weeks is a bit late if I'm going to do something about gestational diabetes, for example. Yes, I'll put you on meds, but if we started earlier,
we'd probably have better outcomes.
Have had better outcomes. Or you have hypertension or high blood pressure in pregnancy. If you came slightly earlier, we would have sorted it out. So I find even for the moms who call the helpline, if I nilienda clinic hapa, or I went for the clinic here and here, then I was told to go to a bigger hospital.
Right.
There's no mention of what bigger hospital, follow-up of did you go, did you not go. So now they call you in labor because they have no idea what this bigger hospital is. They know their case is not for a smaller hospital, so they're stranded.
Okay. So we still do have significant gaps.
Yes.
Right.
Yes.
Okay. But I'm also glad that there's the helpline, because then
Yes.
you get to be able to advise so many instead of losing them. Because again, we keep saying loss to follow up, but are we contributing to that loss to follow up? Are we guiding moms well enough that they know where to go and they know what is expected of them when they go, or why? Why are you
they
sending
going?
me to a
Yes.
bigger facility?
Yeah.
And like you said, what is a bigger facility? You know me, I'm looking at the building.
Hapa
Is
ni
it a
kubwa.
bigger facility physically, or are we talking about equipment and the
Level of
kind of
care.
the level of care that you'll be getting, the kind of personnel that you interact with? And then, like you said, we don't really have a good transition to delivery, but even more so, proper care during delivery.
Yes, that's a big
If there
problem.
is feedback I get a lot from moms, is they feel we still have a lot of obstetric abuse, unfortunately, in a lot of the facilities, where you come in and you're really manhandled during labor. And then there are others who just say there was no explanation. Nobody told me what to expect or what is being done or why
Why it's
decisions are
being
being made.
done. Yeah.
And do you need to check me? That checking, and they all really graphically describe how we do vaginal
The checking.
exams. And then because then they say nobody asked for consent, nobody explained what they were doing, it just kept, and then it's never the same face, because again, unfortunately, with a lot of our setups, because you're on a shift system, you might see more than one provider. So we still do have big gaps even during delivery. But I think, just from experience, from conversations I've had, we have our biggest gap postpartum.
Yes.
Once she delivers and we say, good, here's your baby, you know how to latch on to the breast, you know how to clean the navel, you can change diapers, off you go. And that's the end of that. And while I was doing my research on you, one of the videos that stood out for me was a recent one where you're talking about sex after delivery, which is a topic where people are like, I was so happy when I did, because I'm like, people who are doing the Lord's work. Because these are conversations we still shy away from. But are there other things you think postpartum, after delivery, we should still be focusing on instead of just releasing her to go and figure it out?
Oh, many. Oh, my goodness, so many. Oh, my God, from a patient point of view, from a doctor point of view, from a friend point of view. But when I was reading to come here, actually, when I was reading to come here, I realized the WHO actually recommends 4 visits between 0 and 6 weeks. Something I didn't know. I actually didn't know.
Imagine
you know,
that.
I was like,
and if we don't know as the providers,
I was like, huh?
Yeah.
Because they're like 24 hours, which you do, 3 days afterwards, 2 weeks, and of course the 6-week visit. So I think most of that is covered in the hospital. But if you didn't deliver in hospital, you can see the big gap. And as per the last KDHS, I think only 68% deliver in hospital. And that's a big improvement, you know. So what happens to the other 32? So one thing that I will not fault us for is telling women to go to hospital to deliver. One thing I will fault us for is not telling them what to expect during that delivery. Okay, you've mentioned about obstetric abuse. And I think it's beyond that. I think it's just the common decency to explain to someone, I'm going to touch you for this and this reason.
Exactly.
You get like, we're going to check. This check is going to involve this.
Just like we do for everything else.
Exactly. These are my findings as I check. This is the next path.
This is
In
what
4
this
hours
means. When I find this, this is what this means.
So I think that, I don't know, that explanation now it makes people think, you know, by the time you get into a decision of this is obstructed, let's all have reached that point of, and this is obstructed.
It's not a surprise
it's
to
not
the
a
mom.
shock to the mom. You can't have a lady for 36 hours and then now you're like, umekwama cha twende CS. Nimekwama wapi? What is kukwama?
And also, as far as she's concerned, she's been in labor.
Yes.
All these hours.
So they start telling you in your postnatal visit, I labored for 48 hours. And you count, you're like, okay, that's latent phase. We can't exactly count it. Maybe this. So basically, I think postnatal, by the way, is a good avenue for you as a clinician to explain to the mother what transpired during the delivery. You should do it during the process, but after the emotions and the waves pass,
Mhm.
now let's sit down.
Mhm.
This is what happened.
Mhm.
So that you don't leave them scarred
Yeah.
for what
Yeah.
transpired. And it's something I've noticed even with the patients that I've handled. You leave the nurse to continue, then when you come back, they're like, "Uliniacha, doc."
Mm.
Like, I left for 2 hours.
Yes.
I knew you were in good care,
Yeah.
But that's something that I've really learned to be very careful of how I handle patients postpartum.
Mhm.
The other thing postpartum is to figure out by just observing, especially if you've worked with a patient, you can tell if they're down or not.
Mhm.
You
Mhm.
can.
Mhm.
Like the moms I meet, and how are you? Mtoto ako sawa.
Okay,
How are
great. How are
you?
you?
Nyumba iko sawa. Okay,
Yeah.
how are you? Then they break
Exactly.
down.
Yeah.
They
Yeah.
really break down because no one has stopped to ask them, how are
How
you?
they are as a person.
Yeah. And we forget we come from very robust communities,
Mm.
and I really love the community aspect, but then it comes with hujafanya haujafanya. You haven't done, you haven't done. I remember my first baby, I was like, imagine, just shut up.
I mean, you have to speak up for yourself. You do.
Leave me alone. Just leave me alone.
Yeah, because everybody has expectations of you.
Exactly.
Yeah.
On diet, on
Mhm.
the baby gets colic out of just themselves.
Yeah.
Mama hakuli vizuri
Yeah.
and all these things. So I think we need to figure out for the mom, what are you going to eat? No, it's just basic. What are you going to eat? What are you not going to eat, and why?
Mhm.
So that you're just not saying niliambiwa in school like hoho. Like, me, I was told not to eat hohos because they give me gas post CS. And I was like,
Okay, that's random.
all right. Don't
Okay.
eat hoho, beans, cabbage. By the time I was done, I was like,
So what do I
so
eat?
what am I
Yeah.
eating?
What am I
What
eating?
am I eating? I was left with soup. I think
And yet
that's
you're
all I
supposed to produce
had.
enough milk for this baby.
Yeah.
Yeah.
Anyway, so I think there's a lot of focus on, can we focus on what is this mom supposed to eat? What is this mom supposed to do to help with latching?
Mhm.
And when we come and check the tummy and check the calves and all that, can we also check, are those nipples cracked?
Mhm.
It's
Mhm.
basic, but most people
Yeah.
will pass without being checked,
Yeah.
especially if you had a normal delivery,
Mhm.
because you're going to go through the midwife who's going to check the cord and then tell you to go home.
Yeah. Yeah.
Then extensive perineal tears. Please don't labor again. Such small things that
Mhm.
people are not told.
Mhm.
Cesarean, post-cesarean healing. I'm a CS mom of 2.
Mhm.
It's not a joke.
Mhm.
It's not a joke.
Yeah. Yeah.
So
There's a lot of, I think, misinformation around C-sections because
Mhm.
then we have lots of, especially first-time moms. They're pregnant and they come in and they'll say, "I want a C-section. I want a CS. I'm not going to labor. I don't want the
I don't
pain.
want the
I don't want to
pain.
suffer."
I'll
And
deal
then,
with the pain
yeah,
afterwards.
and then we have to really, I personally then coach them through and explain recovery from a C-section is not what you imagine it to be. It's not a walk in the park, especially not because you also have a newborn to look after on top of healing yourself. So unless it's necessary, we should focus on a vaginal birth.
It's actually it was denoted as an emergency.
Mm.
It's a major surgery.
Mm.
In fact,
Yeah.
we should
It's the bloodiest surgery if you think about it.
It is.
No other
Even
surgery
my
would we allow
THH
that
is
kind of
better,
bleeding
mammectomy is
and
better.
chill.
Yeah. Oh, we've lost a
Never.
liter. Okay.
Okay. That's okay. That's fine. We're fine. We're like, what? No, a C-section, by the way it's set up, because of how the uterus is supplied with blood flow, is the bloodiest of surgeries. And yet, we don't prepare mothers for what's going to happen
Yes.
intra-op. A lot of times we've done really well with supplementation because of focused antenatal care. But in the private practice side where I practice, most people think, oh no, you're only pushing supplements because,
You want to
money-making scheme,
Yeah.
or no, I can handle this on diet. So you kind of have to sit down and explain this in even more detail because
Actually have a testimony on that. Let me tell you, my first baby, I feel like I came here to vent. My first baby, I was on supplements as a good student, My second
first
one,
moms tend to be.
My second one was like diet. Yeah.
I'm a naturopath. I can do this
Yes.
through my diet.
Afterwards, I felt my bones weakening, my teeth weakening. I had to be given IV ferrous, by the way, IV. And I was like, really, I could have just popped
Taken my
those pills.
supplements.
I would have just And I think also postpartum, people forget that you're supposed to be on that. For example, IFAS for another 3 months. They forget because you lost a lot of blood.
Yes, you lost a lot of blood. You're breastfeeding. There's high demand there as well, and so it's not as plain and simple as saying we have created a one size fits all and now everybody has to fit in it. No, it's just a guide, but it's based off of best practice, evidence based practice, because we know the outcomes that you get with someone who has anemia at the point of delivery is,
They're not
I mean,
good. They're not good.
they're not good. So then just encouraging moms and having these conversations, because again, like you said, the gap is not necessarily quality of care. Sometimes it's information.
Yes.
Because we don't have, in those busy hospitals, busy clinics, you don't have enough time to have
sit
a
and
20-minute
talk.
conversation with each and every mother. COVID made it worse because then partners were not allowed in because we were social distancing. And so then any questions, if she forgot to ask, that's
It's
that.
gone.
Or if we even have the time, because I remember Kenyatta very clearly, despite the fact that it was so many years ago, where I literally you walk in and in the next 3 hours you have 35 patients.
Yes, and you have to finish
And
because
you
there's a
must finish.
postnatal clinic
Yes,
coming.
yeah. And if you want to have a chance, half a chance of eating something in between,
Takula Benguni.
you must keep everything to literally 5 minutes.
Yes.
In fact, I don't even remember seeing faces at that time. And unfortunately, that's how the situation was set up. So having now been working in the public sector and then private sector and seeing the difference, we still don't have as much time as we'd want to. But I think most of us are more conscious about what to educate on with each visit. You sort of highlight this and this and this for this visit. I need you to remember this and this and this. Then we come to birth plan. Let's discuss the nitty-gritties of it because that's another gap. Nobody really has that conversation with you. And even when you do, it tends to be limited only to mode of delivery.
Yes.
Whether it will be a vaginal versus C-section.
Yes.
So I think we still have a lot of gaps where as healthcare providers, and that's, again, half of the audience tends to be people who have not done medicine. The other half is healthcare providers, because then I think soft skills is where we still have a bit of a gap.
Yes.
I don't think med school teaches us well enough. I don't think it has the capacity also, because there's so much to learn. Yeah, there's volumes of information. But there are skills that you sort of have to be conscious to pick up along the way. And even if you have 10 minutes with a patient, there's a lot you can highlight in those 10 minutes, as well as the physical exam, just so that a mom who has gone for all 8 of her clinics
is a better mom than the one who did not go to hospital.
Doesn't come into labor looking
confused. Yes. Right? Yes. Let me tell you, I noted that gap, and it's a big gap. I actually started a program called Pregnancy University. I just launched it. I think it's 3 weeks now. We did a workshop. In that workshop, we covered each and every step from physiology to emotional changes. And I want you to come with your husband, because someone is going to throw a slipper at you sometimes. Please don't. Please don't talk about communication. Please try not to.
Let's not resort to violence.
You know, violence is both ways, so please don't.
Yeah.
But I realized that there's a big gap in terms of understanding what's happening in changes of the body, and then emotional changes of the body. And if we can be able to explain this and then bring the partner in, so that it's not a solo journey.
Yeah.
Because if you're going through that journey alone, especially antepartum, it will be bigger or louder postpartum, because our society has taught us that moms are the solo parents. Like, we're together, but I'm the solo parent.
Yeah.
So when you bring the partner in from earlier, then I'm very sure I'm saying partner.
Yes.
I'm very sure I'm saying partner.
Thank you very much.
Yeah. Because society has changed, you know. But whether you're married or this baby is a project together, you know. So let's parent together. So bringing in the partner, planning around birth finances, planning about labor delivery, and explaining when you're still sober, this is a normal delivery, this is a vacuum delivery, this is a cesarean delivery. But now we focus also on postpartum, what happens, so that by the time you're done with that modular course or whatever workshop or whatever way we set it up, you're better prepared. You're not going to hospital to say, but no, I don't want epidural, or I want epidural, and you know why you're asking for these things, you know. And then postpartum, it also allows you to realize early, this postpartum blues. Is this postpartum? Am I sinking into depression? And allowing yourself to quickly get the strategies to get yourself out of that place. Because there's a lot of, and we don't talk about it, but there's a lot of blues which can really sink to depression postpartum. And that's what kills most babies, leave alone moms, most babies, because I don't have the mental capacity to take care of you crying all the time. And the first 4 weeks, babies can cry. You know, or alternatively, they can sleep so much. And you're thinking my baby is good, and yet your baby is.
And yet you should be checking in. You should try and rouse them and see what's going on.
So that I find that if I prepare you early for something, then when it happens, you're not shocked. You know these are the steps to take to move past it. So and I think that's another thing as healthcare providers. We sometimes are, as we said, organically we may not be able to do it because of the large volumes of numbers. Like I went to a clinic that sees 60 patients and it's one person. My goodness, every day for 4 days. How do you do it?
Exactly.
But I think those are the spaces that things like telehealth, for example, can come in and support. Mom support groups can come in and
Especially,
support. You know, because if I as a mom have gone through it and you come and I can see this challenge, I can speak out on it. There's sorry, I'm a bit spiritual. There's a verse in the Bible that talks about older women teaching younger women. And I used to wonder, why are you telling older women to teach younger women to be good wives and good mothers? I was like, you know,
the question becomes as who?
But seeing how moms are supporting other moms, you realize why it was an older, and it's not older in terms of age. It's older in terms of I've experienced it. And then now, if you come to experience it, I can give you my hindsight of this is what I would have done better.
Exactly, yeah. And I think we see a lot more now. We have a lot more mom support groups. There's no shame around it. There's also lots of support groups around other gynecological issues as well. And I think it's a brilliant thing. And for healthcare providers to come on board with those groups and provide some training, provide some insights, share information, just so that, because again, they can spiral. There's a line.
That thin line.
Because sometimes the rumors I see circulating there, I'm like, no, that's not treatment for this. Please don't do that to the baby. Please don't do that to the mom. And so just participating more in your communities, even if you're not able to speak to every single one of those 60 patients you're seeing per day, at least if you take a bit of extra time and participate in online support groups, WhatsApp groups, some are on social media, some
what you're doing.
Exactly, and just educate as much as you can, so that then they have sources of accurate information, so that if I'm going to support another mom, I have the right information on board, or at least I know where to refer if it's something that I don't understand fully. And I think instead of fighting, because I think there's always that conflict between shouldn't you be talking to a doctor instead of talking to another mom. I think both go well together, and they can actually work with the proper guidance. They can work really, really well together. And again, not just doctors, but all other healthcare providers. The more training we have, the better. And the more we go out and share information, the better. And I'd want to just close off by going back to Wills for Life. How can we, I'm a mom to be, how can we as mom to be, not literally,
I'm grateful. Amen.
Well, I saw how that one will end.
Amen.
If I am a mom, hypothetically speaking, I'm on the journey towards motherhood. How can I reach out to Wheels for Life? Is there is it WhatsApp group? Is it a physical group? How can I reach out and how can I get support from you?
Many ways.
Mhm.
If you're in an emergency,
Mhm.
please call the helpline
Okay.
1196. It's always manned by doctors.
1196. Okay.
1196. It's
Mhm.
always manned by doctors. So if in an emergency, please, that's the line to go to.
Mhm.
If it's not an emergency, you can meet us through our socials
Mhm.
so that we can able to add you onto the group.
Okay.
We have, as I've said, we have the WhatsApp community group and we have the Play Store app.
Mhm.
So, but the major bulk of our work is in the support group, in the mom WhatsApp community group. So the number is, I'll give you, 0719 116611.
Okay.
116611.
Yeah,
Itaekwa
we'll
kwa
put
kupi-
in the
itaekwa hapo.
the description box
Hapo mahali.
down here.
Yes,
Yeah.
but I think if you find us on our socials, we'll always have someone behind who can check and be able to plug you. We have two groups that are WhatsApp based. The one, the doctors themselves respond to each and every most of the questions.
Mhm.
Yeah.
Mhm.
So we have pediatricians, diabetologists, obstetricians, we have physicians, dermatologists. All those are in that particular group,
Mhm.
and we made it 150 a month. So
Okay.
it's
Okay.
quite
Yeah,
affordable.
it's affordable.
Then we have the free groups where now we have the doctors there, but we only come in to correct when we see, this one,
Yeah,
now
this
you're
one
lying.
you've
Now you're
gone-
lying.
You've gone against the grain.
Yes.
Yeah.
And then also because we're very keen on supporting moms to grow as well, we have what we call a market group
Okay.
so that they can showcase and product
Oh,
to
nice.
one
Okay,
another
okay.
and just
Yeah.
grow financially as well.
Full women empowerment. I love it. I love it.
And
Okay.
then now we have monthly physical meetups depending on which county. So where we do now the coaching, like the 1 day workshop, we are focusing on labor, one we are focusing on baby, such.
Does Wheels for Life need support?
Oh, a lot. Jeez.
Because
a
sometimes we
lot.
make assumptions. Sounds like it's running well. Does Wheels for Life need support? And if so, how can we reach out to support?
If you're a healthcare practitioner, please, we need as many healthcare practitioners as we can get to be
Yeah.
able to support the women that we have. We're trying to meet as many, we have a target of 1 million.
Oh, nice.
Women.
Oh, I like it. Okay,
Huge
that's
number.
ambitious.
Very
Fantastic.
ambitious.
Yeah.
So if you're able to give your expertise, even if it's just one text, it goes a long, one text or WhatsApp, it goes a long way. If you're able to support financially, we still provide transport to hospitals
Right.
when someone is in need. It's not as rampant now because we prepare them early and in
Right.
advance.
Fantastic. Yeah. Mitigate the problem. in
But for
advance.
those who still need that kind of support, please, if you're able to, cab goes, we use cabs and ambulances.
Okay.
A cab goes for 500 to 1,000 Kenya shillings, depending on the county. An ambulance goes for a good 10,000 shillings. So wherever
No
you're
surprises
able,
there. But again, it's specialized support.
Yes.
That's someone who
Especially
needs,
advanced
yeah.
ACLS ambulances. So wherever you're able to plug in, please do. We'd really, really love the support. Again, we'll give the numbers to Dr. here so that you're able to plug in. But beyond that is to support the woman next to you. So sometimes we run to support others and we forget your wife, your best friend, your family member. Because if that person has the support they require, they support another mom and it becomes a movement. So support us, thank you. And also support the one who's next to you.
Right. For me, the closing question will be around speaking to moms to be and new moms. Do you have any tips for them for self-care? Because again, like you said, we forget the woman. We focus on her role as a mother, and being a mother is looking after someone else. We're not looking after yourself. So any last tips you can give to moms to be or new moms in terms of looking after themselves?
I think the biggest would be to have time for yourself. I think that's the biggest thing I would say. Egg out an hour for just you every day and do what you love to do. Whether that's taking a walk, whether that's singing in the shower badly or goodly.
Like some of us.
But egg out an hour and create a system in your house, especially when you're on maternity leave, because your house becomes a shell and it can become a prison actually. So create a system that you can walk out for 2 hours and the house won't collapse. Okay. Whether that's having a sister around, a friend, home care, it doesn't matter.
Yeah.
Create a system that you can allow you to walk out for an hour and you're comfortable. And if that system is difficult to create initially, find out why. Find out, is it because there's no food? If there is no food, cook on Sunday, put it in the fridge. And if anyone is like, I have to eat fresh food, no problem, enter the jiko yourself.
Exactly.
As in, create a system that loves you so much that it can allow you to be selfish with your time. Because I know the biggest challenge when you have a new baby is you're scared to even shower so that the baby doesn't fall. Babies are very, very predictable. And they have a set routine. If you learn their routine, you can
walk around
their schedule. For example, most babies will sleep in the first 4 weeks, they sleep 20 hours, 18 to 20 hours with gaps of 3 hours. In 3 hours, you can make your hair and come back home, So don't feel guilty for going for a walk. Don't feel guilty for going for ice cream. Don't feel guilty for ordering ice cream to come to you if you can't leave the house. Don't feel guilty for wearing a mama toto wrap or whatever they are and walk out with that baby. And if anyone tries to make you feel guilty for it, just for that time and space, guard your energy against them. The other thing is to ask for help. Unashamedly ask for help. For example, today I'm here. I've left my baby with the grandmother who's also at work. I'm like, Mom, sort it out. You sort
exactly.
it out. So ask for help.
And I think also accept help.
Yes.
Some of the mummies, the struggle is, like you said, mom guilt.
Yes.
So then you feel like no one else can take care of my baby
as
like
good
me.
As I can, as much.
Which then means you can never get time off. If that's the mentality that you have, it becomes very difficult to allow others, because some people do have support, but they don't lean on that support.
They don't want to give out. For example, when I see clinics, and if you come from my clinic as a postpartum mom, you'll be shocked because I'll ask you, umekuja peke yako? That's the first question I'll ask you. Nimekuja na msichana, kuja kae hapa. So that I see, are you able to hand over the baby?
Exactly.
Are you able to hand? If you're on the bed, I'm trying to examine you and your head is like this. We'll sit for 10 minutes. I'll look for it. I'll tell you about the importance of just having someone else carry that baby. Because what happens when you die?
Because you're headed in that direction. You have to look after yourself.
And sometimes I say you have to be selfish with yourself so that you're able to be selfish with them and take care of them.
You can actually look after other people.
So if you're able to accept help, and accepting help is hard, Claire, is hard. When you pick the baby and the baby whines, and especially in the beginning when they're adjusting to dad, because they already know you, when they're adjusting to dad, there's that tendency of ama umeshika shingo vibaya, ama umefanya ama
shika vile nimekuonyesha. Only
let me tell you, that baby, the father is also the genes here. Allow those genes to figure themselves out. So sometimes I sit down and watch them cry. You figure yourself
out.
When you figure, if you're unable to, then I'll come in. And I think it's the same thing we do with businesses. You try and if I'm not the one seeing this patient, and this patient will walk out and go and be seen by someone else, So allow that independence. And I think motherhood or parenting is teaching your children so well that they can live without you. The day they can live without you, you've succeeded.
You've succeeded as a mom. That's true. That's true. I like that advice. I really do. And I think I'll leave it on that note. Again, thank you so much for coming on for this episode. As I said, all your details will be in the description box below. Feel free to reach out to her directly, to reach out to Wheels for Life as well. All the social handles as well will be in the description box. It's been a fantastic episode. I think I need more mom-based episodes. That's what I'm seeing. And if we summon you, will you be back?
I'll be back. I'll travel.
Where are you based?
Right now in Nakuru.
Okay.
CK Patel building 9th floor.
Oh, nice. Okay. So if anyone is looking for her physically, that's Nakuru. You have a fantastic gynecologist you can reach out to. And for this episode, I want to just call it a wrap there. Thank you so much for watching or for listening in. If you're one of our audio listeners, thank you so much. From what I've seen, you come from across the globe now. Keep engaging, keep reaching out. If you're still shy, send those DMs and those emails. Otherwise, leave a comment when you see the posts. Leave a comment on YouTube as well. We'll reach out and we'll be eager to respond. Thank you so much for tuning in, and I look forward to seeing you on the next episode.